All right. I was going to say good morning, but it's not good morning. It's good afternoon, Tracy. I don't know about you, but as soon as it hits 12 o'clock, I feel like we all change at work. So how to sort of greet somebody. Thank you for being here.
Good afternoon, then. The changeover.
You got it. Thank you so much for agreeing to this is your lunch hour. I know you just finished up with a client, and right after this call, you'll be helping somebody else. So thank you for taking time out of your day to talk with us, talk to our patients, our team about something that you're really an expert in, which is trauma-informed care. We really appreciate having you.
Oh, thank you so much for having me. I am really excited about it, and I'm really passionate about the work that you do and being able to bridge both of those things. So thank you very much for inviting me to be here today.
Absolutely. I want to give a little sort of set the stage introduction to how this all came about. And basically, we had Tracy, who's been a longtime friend of Choice PT, and we were talking about what you do on a daily basis and how we are always looking to look into ways to train our team and improve our patient experience and learn more about the people who come through our doors every day. And trauma informed care is one of these ways where we understand that everybody has different lived experiences. And the hope is that not many people have had experience with, but you're going to tell us how common it actually is. And to keep this in the forefront for not only our patients to know we do practice this type of care, but also our team to always be mindful of everybody is living a different story and to know different techniques or ways to make people feel comfortable. So I know about just under a month ago, you came and gave a lunchtime in service to our team at Campbell Lab. And we're hoping that this is an option to be able to meet more ears or get to other listeners. So if you don't mind, could you just tell us a little bit about your background, what all of these letters next to your name mean, and explain to us sort of where this is coming from?
Sure. So I'm Tracy Gilbert. I'm a registered art therapist and a licensed mental health counselor, and I have a private practice in Schenectady. I have been doing this work since about 2005, and I work mostly with teen girls and young adult women, mostly helping folks who have anxiety or trauma experiences, really working on empowerment and helping folks just have a better sense of self and coming out of some tough experiences and finding a better place in space and having their voices be heard. I find my work extremely fulfilling, and I can't imagine doing anything else. And I love being able to put some creativity and joy into the world. So, and the thing that I love, you were very wonderful to say friend of Choice PT, and I definitely would put myself that way too. I'm also proud to say that I have utilized physical therapy services at Choice as well, and it's one of the things that I would be very that I'm very pleased to say is that I think that prior to me coming into doing the in-service at Choice was already trauma informed, and I don't think you even knew it. So I think you already had a commitment to being a very welcoming place that had a good commitment to it without even having that language. Wow. So we'll get to that language in a bit, but set the stage for that. So.
Well, thank you for that. Thank you so much. So, and one thing that hopefully everybody who does see this is going to see the passion and just the ability and the professionalism that Tracy has. And I know that this is only one segment of what you do, right? Everybody, I'm sure throughout your clients, there's different ways that you try to work through talk therapy and art therapy and being able to provide a space for people to heal. But today we're going to talk specifically about trauma and what it is. And so if that's not the best segue, I'd love you to explain what trauma is. And I'm going to come on and off because Tracy has created a great slideshow that can put some words to her own thoughts. And so if you could explain to us a little bit about what trauma is and sort of how it shows up.
Sure, absolutely. So there's a terrific definition that according to the APA, trauma is an emotional response to a terrible event like an accident, rape, or natural disaster. Immediately after the event, shock and denial are typical. Longer-term reactions include unpredictable emotions, flashbacks, strained relationships, and even physical symptoms like headaches or nausea. That's the technical definition. The thing about trauma is that it's really different for everyone, and the experience is different, meaning that two people could go through the same event and have a completely different experience. It's that you're feeling that helplessness, that hopelessness, that just things aren't right in the world. I don't feel safe anymore. I feel so untethered. That scared response, and it can come from a variety of different experiences. There are a whole bunch of categories of trauma that we'll get into, but that's a broad definition that really can lead to a huge amount of experiences.
That's one thing I'd like to reiterate when I first learned about this, that you don't really think about what one person has happened to them and the way it's perceived or felt, or the emotion that comes from it could be, and most likely is going to be, completely different to the same exact stimulus.
Mhm.
And that can be whether it's building on from a previous experience or someone's first time. So I think that your understanding to that, or you're letting us know that different experiences do happen, different trauma can happen to different people, and it's felt, it might look very different in different people.
And there's also an acuteness, so you can have like an acute traumatic response, so like a brief experience of like, I felt this traumatic response immediately after it happened, right? Like that shock response right after something. And then there's that long-term effect, and it's more the long-term respect that you're probably going to be experiencing as you have people come into your practice. But in general, the trauma responses are fight, flight, freeze, and fawn. So fight, fighting back; flight, running away, let's get out of here; freeze, like that deer in headlights response; and fawning is a newer term that not a lot of people talk about as much, but it's really ignoring personal feelings and trying to please others to avoid conflict. I think we probably see that happen a lot in day-to-day experiences and don't even know we're doing it. Often people have a primary response that they're using that's sort of the like go-to trauma response, and then if that one's not working, they kick in the other ones. For example, if you're triggered by something and fight is your response, and fighting is not working, then maybe you kick into, I got to get out of here. Fighting is not working. And then, oh, that one didn't work, I'm going to try the other one. And you cycle through until something is going to work.
Okay, so it's not always, you don't do just one. There could be, you do one immediately and then maybe another
Right.
response, and it could also vary. And you gave the broad definition, and so trauma can show up in different ways as well. And so I'm going to show this next slide because I think it's interesting, because I didn't always think that some of these categories would be classified. So if you want to touch on basic what some of these types of trauma are, I think that'd be super helpful, knowing what our response would be.
Absolutely. So types of trauma include bullying, community violence. I'm going to come back to complex trauma in just a minute, but response to disasters, early childhood trauma, historical trauma, meaning trauma over time, trauma that carries from one generation to another, intimate partner violence, or what used to be called domestic violence, medical trauma, could be a trauma in regards to a surgery or what happened with just
the event of having to have something medical happen, the loss of something medically, physical abuse, religious trauma, sexual abuse, sex trafficking, terrorism or violence, and traumatic grief. One of the things that I should say that's not listed in here, and it's down at the bottom and probably too tiny to see, is that racism, homophobia, xenophobia, things like that. This is where it gets a little tricky, that those things are not necessarily considered types of trauma, but are underlying things that make up so many pieces of these traumas that are they're such a big piece of how it's interwoven that they're the constructs behind so much of this, but it's not a specific kind of trauma for the for that particular person, let's say. So so the community violence could touch on a bunch of different things, and definitely could have an element of the traumatic event really stemming in racism, let's say, but the racism is not necessarily the trauma. There could be much more complex elements of that, and that's where the complex trauma comes into play. That's just one element, for example.
And I can see how, there's not a clear cut and dry answer. And it's almost like through that description there, I'm sure you know that there's multiple layers and it's interwoven. And there could be somebody who's dealing with different poverty, racism, and also including historical trauma.
100%.
I think I was hearing you that it's because it isn't a category in itself, like recognized as a type of trauma, but it's an underlying layer that can feed into how that person is feeling.
And I want to make sure that I'm being clear that it doesn't discount any of that, and nor does it can be tricky that because I'm presenting it that way, I want to make sure I'm not making it sound like I'm undermining any of that in whatever we're talking about, with it being homophobia or poverty or racism or any of that stuff, that those things are super, super important. It just from a trauma category standpoint, they're not their own categories. So just important elements that they aren't their own.
Yeah, no, if anything, I think you're giving it more of a space. So I don't think you are undermining. I think you are, naturally, it wasn't on that list that I was just showing. So if anything, I think you are inclusive of knowing that there are other factors as well. So I appreciate you just adding that extra piece. But you did say you wanted to come back to complex trauma.
So thank you very much. I appreciate that. So complex trauma is honestly, it's a little bit more of what makes trauma so tricky, because complex trauma is when you have someone who has had multiple traumatic events and they've compounded over time. So it's really hard to pick apart the different pieces of it when it's really compounded. I mean, I don't have the medical background, but I think, I'm guessing, and you tell me how accurate this might be from a metaphor standpoint, that if you're fixing a fracture versus a compound fracture, you have it's a far harder situation. Yeah.
Absolutely. I like the metaphor.
So it's a really similar thing, that if you had one traumatic event versus this one that led into this one that splintered off into this one, boom, terrible, you have a far harder piece to be dealing with. So if you have a family situation, a community situation, something that happened in childhood, all of that kind of interwoven, and then just as you're recovering from that, something else happens. That's a huge amount of stuff to try to get through in your body.
Yeah. No, thank you for clarifying that. And I jotted down a few things of what we see in physical therapy, and we'll get back to those a little bit later. So you mentioned childhood experiences.
Mm-hmm.
So there is you've taught us about what is called an ACE or an ACE score, and this was the first time several of us at Choice when you went through, because unless you're in a school-age environment or where possibly you have been given this by one of your colleagues or your job, it might not be a common questionnaire per se, but can you explain what is an ACE score, and maybe how do you use this in your line of work?
Sure. So ACE stands for Adverse Childhood Experiences. So CDC Kaiser Permanente is a large healthcare system, mostly based in California. Many, many years ago, they did this massive study. It started out with something like 17,000 people. And they started doing a 10-question survey that was based on questions about early childhood experiences, specifically adverse early childhood experiences. And they started to collect data on these early childhood experiences and realized that there were correlations between these adverse early childhood experiences and people's health conditions or life experiences later on. So they found that in general, the more adverse childhood experiences someone had, the greater the correlation to adverse health conditions later on, the greater the correlation to unhealthy lifestyles like smoking, like heavier drinking, like trouble keeping consistent employment, things like that. Links to suicide, links to shortened life expectancy. So the thing about this study is that the people that they surveyed, all of them had health insurance. So all of them were getting health care. So it was a pretty interesting study in that the population were all people that were getting healthcare treatment. So if you, A, it was a large survey, and B, they were all getting healthcare. So it'd be interesting to see how the numbers would be adjusted if they were not getting healthcare treatment, right? Because right?
Yeah.
And the bulk of the population that they surveyed was also white and had a telephone. So because they had to take the survey at the beginning and at the end, because this was quite a while before I think most people had home phones. So again, had access to resources to have a phone and had to be willing to do the survey at the end. So that's a lot of things that really added to the survey. So even with that, they found that 2/3 of the over 17,000 people in the initial study had at least one early childhood experience. That's wild that many people in that group had that many early childhood experiences. And so of the people that had those early childhood experiences, just the different things that were correlated as the numbers went up, they found that if somebody had an ACE score of 4, that was kind of the cutoff of when things started to get really scary. You had an ACE score of 4 and up, the correlation between that and what things correlated with some very bad outcomes got very, very serious. So the jump off of the health risks for somebody with a 1 versus the health risks with somebody with a 4. I mean, it was like, well, so good news, bad news. I mean, the bad news was, wow, these numbers are super, super scary. Good news, we can do something about it. So there's this amazing pediatrician who I believe is the Surgeon General right now for state of California. Her name is Dr. Nadine Burke-Harris. She's amazing. She has great TED Talks, public service announcement.
Okay, good.
Yeah, she's, this is actually her book right here. Fantastic.
I love learning about
this announcement. Yes. So
we love learning new books. So thank you for sharing that.
anyway, so she and a number of other providers have been really committed to doing amazing work in pediatricians' practices and trying to roll out things in early childhood practices to try to prevent some of these early childhood experiences from taking root, to try to get things as stable as possible in childhood so that these outcomes are better. The good news is, we can change a lot of these outcomes. We can make things, be not as long-term traumatic. You can fix a broken bone. You can help trauma turn into a healed experience. There are things you can do. It's not a permanent dead zone. So
yeah, and I think that knowing how prevalent it is and knowing what you're saying, and I know I can't speak for several decades, but the stigma behind getting help and behind mental health was so strong. And I know that those walls and those barriers are slowly getting broken down, and that, getting mental health counseling, it can only help somebody who's had this. So hopefully the thought process is currently changed from previous, because I think that, to your point, the Kaiser Permanente study doesn't show a true reflection of maybe how many ACEs are happening, knowing that there are some study limitations to who could have taken it. So I appreciate you sort of setting that stage with how often this is happening, and also what the indicators are if you have more than 4, and how that we have to be a little bit more alert to people who you don't go around and really. And so that was one thing that Tracy challenged us at Choice. How can we get this type of questionnaire or something into our patients at that initial evaluation, or at that attempt to give somebody the opportunity to at least write down that they do have some background here, so that we can be more in tune to knowing that about our patients, because we do a lengthy past medical history, and that those types of questions don't really fall on some types of healthcare, or specifically outpatient physical therapy. So I know when Tracy's coming back in November, she's going to see what have we changed to be more well-rounded in this area.
And what we talked about, Erin, is that, especially given those statistics, it really is a we thing, not a they thing, right? And so a lot of people tend to think, oh, it's other people's patients, it's other people out there. Well, if it's like 87% of people have at least one of those adverse childhood experiences, it's really a we thing. So if you're in a group of people and it's 87% of the people around you have at least one, it's we. So if we need to be working on that, then,
Yeah, we need to talk about it. We need to talk about it more, and we need to normalize it, and know that we need to help on different ways, so that I know we had a conversation that it's not only put up on the shoulders of our licensed mental health counselors and on our psychiatrists and psychologists. Why can't other realms of physical therapy try to do our part to understand the problem and provide another resource? So, and I realized I popped out, but I wanted to sort of add, when I go off screen, I can't talk. So if you I'm like, wait, I wanted to say something, but I'm not on.
Well, and I guess to add on to that we thing is, that's the we that's reporting.
Right.
So likely it's a lot higher than 87%.
True. 100%. I can unfortunately would understand that. All right. Do you want to talk about just these? So we're jumping from so far, if you're following, we talked about what trauma is, what types of responses our bodies do, and how they differ amongst each other. We talked about the types of trauma and how there's several categories, and then some that really don't even fall under a category, but we have to be thinking about those people. We talked about the prevalence, how we know how often and how many people sitting right next to us in our workplaces, in our friend groups, how many might have been affected by this in the past or currently. I think there's a lot of current trauma that is still happening that we should also be mindful of. So I'm going to pop back off because this slide gives some great other statistics of really why it's a problem.
Yep. So these statistics, this is just a quick sample of statistics. So by no means is this complete. Oh, you could go down such a wormhole in statistics, but about a quarter of traumatically injured patients experience PTSD or depression post-injury, and approximately 20 or 30 of ICU patients experience PTSD symptoms. So that's a lot of people that could be coming into physical therapy, who could be going to a therapeutic rehab session situation, who could be coming back home. That's an awful lot of people who had ill effects in some way from some medical experience, either because of the treatment, because of their own medical stuff, because of the loss of whatever, who knows, but whatever it is, had a really tough situation and are now having to be experiencing the world, and they're going to need a lot of support. So as many as 1 in 4 girls, as many as 1 in 6 boys are affected by sexual abuse. There is a terrific resource called the Mama Bear Effect that I love. If you have, especially if you're a parent, if you have nieces or nephews, cousins, whatever, small children in your life, highly recommend the Mama Bear Effect. They're an amazing resource, really terrific literature. So one really important thing to know about that especially is that about 30 or 4% of perpetrators are usually immediate or extended family members of the victim, and that less than 1% of child sex abuse allegations are false. And I am somebody that has worked with an awful lot of sex abuse survivors, children and adults. I can't think of anybody that I have known personally that would want to make up those allegations and would want to go through the investigations and the things that they have had to go through. The pain and suffering is way too much. So, and it's happening far more and far more prevalently than one would imagine. And it's not a stranger danger situation. So this kind of thing, again, it's really about awareness and just knowing good boundaries and who folks are with. So Mama Bear Effect, that's my plug there. On average, more than 1 in 3 women, 1 in 4 men experience rape, physical violence, and or stalking by an intimate partner. 1 in 10 high school students has experienced physical violence from a partner. That's a pretty significant statistic. Locally, Wellspring is a fantastic organization that does intimate partner violence support. I have resources listed at the end, and they're a really good organization that can help out a lot if you or someone you know needs help with intimate partner violence. They have a 24-hour chat line. Let's see what else we have here. This is a pretty wild statistic. Preschoolers are 3 times more likely to be expelled than kids in elementary, middle, and high school. And I can't even imagine how COVID has affected that. I wouldn't even imagine how to extrapolate on that. Boys are 4 times more likely than girls, and African American children twice as likely as Latinx and white children. So that's pretty traumatic experiences for school-age kids who, they're in school at least like 30 hours a week. And that's a lot of places that are in theory supposed to be safe, productive, and like a good place of growth. So another super important statistic is that suicide is the second leading cause of death among 10 to 34-year-olds. And so there's some resources at the end of this slide presentation. We can stick it up too. The Trevor Project and the National Suicide Prevention Hotline are both terrific resources if you or someone you know needs some help with suicide prevention. They have a 24-hour chat line for each. They have a what's called a warm line, so you can be chatting on their website as well, phone number. But especially right now with people in isolation, those things are really, really important. It will never, ever make someone complete suicide by asking about it. And if anything, it may just stop someone from completing suicide.
Well, I off screen was, it's hard not to shake your head or think about that. That's true. And we already know most things that are given a statistic is not, it's a representation, but there's so many more people. So I thank you for just going over that. So I think people, it's important to talk about it. And it's also eye opening to know, you think, and you dubbed it stranger danger. I think growing up, or that's what you think it is. It's somebody driving by and asking you to get in a van, or, I hate to use that, but that's what we're taught as kids, or don't go into a stranger's car, don't talk. But this is proving that sometimes it's not always, it can still, but it might be more likely that it's someone who is actually familiar with this person. So keeping that.
Now, I mean, off the top of my head, I think it's something like 8%
really
sexual assaults are strangers. Yeah. I mean, it's so unbelievably rare.
Wow. Well, yeah. So we know it's a problem, and we talked when Tracy and I were talking about what's the best way. And I know it doesn't feel good to talk about this. And I'm sure in your line, when you are working with clients, you have to face the harder facts. You have to address what's right in front of somebody, and sort of to get that wall down and to have people start talking about it. So that's why we at Choice, we do have challenging conversations to know that the growth that can come after that pain can sometimes be better. And so what we wanted to talk about and sort of lean into is why on Choice, why with physical therapy, and how can this maybe serve some of the patients that we are fortunate to be able to treat. And I just wanted to say that, one, we're already better from learning from you, Tracy, and from hosting this, and preparing. It's a means to give back to our community, on our team, and our patients. But I want to also spend a few minutes to just say, okay, so we have physical therapy, and when you were listing out the types of trauma, we would fall under some of those categories for the person who, and I can think off of true patients who had a major car accident, so that medical trauma, or multiple. I can't tell you, people have said, oh, I fell off a roof and then I got hit by a car, or we have had some gunshot violence, or not that the main cause was some sort of domestic violence, but we've had that too, having been open now for a few years. So we are seeing patients who, whether it's on their prescription or not, or some patients now with direct access, you don't need a prescription to come in. So it's our job to sort of ask these questions of our patients after there's some rapport that's been built, but to be able to maybe see who has had an experience like this. So I think being aware and knowing that we are informed that this is, like, our patients are team members. It's not just patients. You just gave the statistics. So knowing that amongst ourselves in our break room or our interactions with our patients, it's how can we keep this top of mind. I'm going to pull up a slide, because this, although created by Tracy, I thought it was interesting on ways that you can, it's not necessarily lightening the mood, although we try to lighten the mood, not just for trauma-informed care, but it's a way that things that we do in Choice that can make either somebody who's going through a tough time feel less pressure or less of those triggers. I know that's a sort of a common word that's used amongst your clients. So I can bring it on and maybe it won't kick me off, but so it probably will. I can't read. My vision's really going. So these are just different ways. And maybe, Tracy, would you want to go through them, or do you want me to? Because I can do either one.
It's totally up to you.
Okay. Well, I'll do it, and I'll just, I don't want to kick you off though. So with keeping the slide there. So some things that we are mindful of here is the actual physical space between ourselves and our patients, and knowing, although sometimes we are hands-on therapists, it's asking or talking about the next treatment we're going to be doing, or letting a person know, okay, I'm going to have you lie down now. I'm going to be working on your neck. So if you don't mind, I can turn off the lights to make that better on your vision. Or so it's always educating one step ahead so that our patients know what to expect, rather than all of a sudden just, taking the shoulder and sort of moving it around without either asking for permission or giving that heads up. So that was one area there. Another thing is about the tone of voice that we're using. And that's something we pick up on body language, or how a person's, if there is some, it's not always having that overly boisterous volume, and knowing that having to adjust that for our patients is something that we can control. So then our treatment spaces, we consciously made the option to have private treatment spaces versus gym spaces. And I think when you came, and actually the conversation that next week afterwards, some people, when we asked, do you prefer, we always at the initial eval say, do you prefer a male or a female? And then we will get answers to that. So that's one way requesting preferences. And then when you come for your visit, do you prefer to be in the gym space where more people are, or in a private room? Because I think, to your point, either option could make people feel less comfortable. So someone in a closed room, that could not be as comfortable as somebody in a wide open space. So having the option to tell your therapist, I'd prefer to work in either space, we try to make that accommodation.
And also, if you're in the room, how's the door?
Right. Yes. And where in the room is that door?
Exactly.
So, are you behind the door so that there is no visual field to other people, or are you in that other side of the room where then you can see out if the door is locked, or whichever? Yes, good point with that. So the other things that are on here is we try to make the space with music on, and asking you what's your favorite song or band or genre of music, and trying to have that playful yet homey atmosphere where people will know what they're going to expect the next time. So there's not that awkward silence, or those are other ways of little intricacies, I guess, about choice. Is there anything else that you want to sort of highlight from how we can, in an outpatient physical therapy space, provide a
So, one of the reasons why I initially started thinking about doing this training is that, honestly, I had a couple clients that had started to see, I see, because I do some telehealth sessions, I have clients that are actually all over the state. And so some clients that were having physical therapy were finding that they had all sorts of different therapists, like never the same person. And what prompted one conversation that I think you and I were having is that, especially as the middle of August came, this particular client had all these interns, and all the interns left. And so over the course of 3 weeks, they had like 3 or 4 different physical therapists, because everybody was cycling through as the interns were leaving and going back to school. And so never once was their treatment plan the same. And so that lack of consistency, that choice has never been that way. Right? So just, you're so committed to, this is your person. And, if something happens, like I'm sure if somebody had an emergency and you had to cancel, you would call and say, listen, and, I can't see you, somebody might call and say, Erin has an emergency. We have to cancel Erin's appointments tomorrow. So we really know that you're wanting to work on your, knee. So we have this person that you can see tomorrow, or Erin could see you on Monday. Which would you prefer? And that person has a choice. But it's not just, and we're going to bounce you to this person, we're going to bounce you to this person. And it's with an intent. and with communication. And the person has the right to say, no, I'll wait for Erin. Thanks, I can manage. Or, no, I really need to get in. And it's that person has literally a choice. And I'm not trying to have a pun on your name, but you have the empowerment of, I was asked, instead of just bounce without a point, and there's the buy-in of, you're an informed consumer.
You're right.
There's a plan.
And I think that was a decision. There are those circumstances, like you say, someone's out sick. So all of a sudden we have, okay, but with there's still the question, Tracy, so Cody went home sick. I am here. I've looked over the plan. Do you feel comfortable seeing me? And then there's still no. And we've had people say, no, I'm sorry. But yeah, it has always been a goal of ours to have the consistency of care, not only for knowing someone's past medical history and their background, but also to have an idea of what their plan of care for their physical goals and their rehabilitative goals and what that looks like. So yeah, thanks for bringing it. And that is something that in other appointments I've had just personally too, you don't want to retell your story, especially if it's not the greatest story to every different provider. So I have been there to say like, oh, I have to say this again, and it's not comfortable. Some people prepare for their appointments to know that that's hard for them to talk about what their illness is or what their past medical history is. So to have to say it time and time again, where, having that consistency of care, you don't have to repeat yourself.
The other thing is, and I don't know how they do it, but all the people that are at the front desk, how they know everybody's name, I have no idea. I don't know if there's photos of everybody and they're just really good at I don't know what they do, but every person that walks in, they're like, hello, Bob, hello, Emma, hello, Jordan, whatever. Like, it's miraculous. Goodbye. I don't know how they do that. I couldn't do that if I tried. And like, it makes everybody, you watch people just light up like, they know me. I'm famous. Like, it's amazing. And you feel like $1 million because everybody knows. You're like, it's just so nice. And like, it's everybody. I don't care who you have at the front. Everybody does that. It's so lovely.
Yeah.
And you just feel like,
I am biased, but our team is the best in the world. I say that, and they're like, Erin. I'm like, well, I only know our team, so I'm going to say that anyway. But and our admin
it makes
team
so much of a difference. I mean, it's really like, I don't remember where I heard this, so I'm stealing it from somewhere.
Okay.
But I heard somewhere that, it's not just about physically showing up, it's about emotionally showing up. And when you are emotionally showing up, people feel seen. And so when you have people at your front desk that are saying hello and goodbye, making eye contact, even if they're on the phone and they're catching your attention and waving and like mouthing, goodbye, Tracy. And you're like, what? Like, you feel seen and like they showed up for me. Yeah. And that's super nice, right? Especially if you showed up and worked really hard and like are, working on some kind of muscle that was sore or whatever, or like you tried really hard and you're like, thank you, I'm going to go home and collapse, whatever that was, exactly. Like, it's really nice. And the other thing that I think about too is like, you have to have a beginning, a middle, and end, right? So when somebody walks in, they're greeted really well. They have the physical therapy session with their practitioner, and then they end really well. And so you have a good beginning, middle, and end.
Yeah.
They're not shuffling in. They're not shuffling. Okay, they might be physically shuffling in, but they're like, they have a container, right? And so like, it's ended well.
Yeah. Well, and I thank you for bringing that up too, because not only on that every day, but also one thing with trauma-informed care is telling the person at their first day what their next couple of weeks look like. Because there's anything I've learned from anxiety and folks who might suffer from wanting to know and what the plan is, we try to, put that out there in the beginning so that there's an understanding that this is a relationship we're going to build on each session you have, and this is something that we're able to have this forum for questions. And I can't tell you, another thing is we notice that some people, they're like, you're graduating me?
Yes.
I'm not ready for this type of thing. And then if I get those eyes and I'm literally like, well, your strength is, your pain is gone, your strength is better, your function is where it was before, if better. So we should probably work towards graduation and having you do this independently. And I'll say like, no, we're not leaving yet. I need a couple more weeks. And for me, I don't know if any people from insurance are listening. I think of that more as great. There's more we can work on. Tell me your hardest week physically. What is it? And let's get you there, because maybe that person emotionally isn't ready to sort of cut ties. And we sort of talked about that last night when we were preparing for this, that there does have to become an end, but it has to be communicated so that it's never just on that last day. Like they show up and they think they have a couple more weeks.
Absolutely.
It's your last day. And it's
no sucker punching.
Yeah. Nope. Right. Well, I wanted to save a couple minutes because you have a patient soon and lunch. So I have you already talked to these resources. So I wanted to pull them back up, and then we can summarize on there are so many resources. So hopefully if anybody who is, I'm going to get off so people can read that. If anybody is looking for those resources that you spoke to, Mama Bear and the local agencies, I think it's important. But if you want to go over this, and I'll put your contact list up right afterwards. Okay.
So, yep, there's some ways to find some local therapists. So one of the things that's tricky is that I'm sure if you're somebody who's been trying to find a therapist, or you know somebody who has, there's a mental health counseling shortage right now. So I know that I have been booked for far longer than I would like to admit, as are most of my colleagues. But these two databases that I have listed right here are two good ways to find therapists. You can plug in your zip code and the kind of insurances you have. So inclusive therapists, I like more than Psychology Today. It's a newer database though, so it doesn't quite have as many therapists, but you can plug in your zip code and then your insurance or things like that if you're looking, and you can really tailor it to what you're looking for in a therapist. Usually it says whether they're taking new clients or not, whether they're doing telehealth or in person, etc. And then the local resources, Wellspring works for intimate partner violence. Then there's also the National Domestic Violence Hotline, the National Suicide Prevention Hotline, as I mentioned before. Locally, the Pride Center of the Capital Region is amazing. The Trevor Project is not local, but is also a good resource. And then I think, let's see. Oh, and the Trans Lifeline is another great one. Yep. So those are all really good local resources for anybody that you know that might be struggling. So thank you so much, Erin.
Sorry about that. That just got fancy. I love some of these things on here. And I do have the email for Tracy. I think you mentioned there's a shortage right now of licensed mental health counselors mental health counselors who are taking patients, but it's about being an advocate for yourself or for somebody who will, there will be an opening, even if it's in a few weeks or so, or wherever that might be.
So the email that you just plugged is the email that you have up there is that the Gmail one up there?
Yes. Is that not correct?
No. That's okay.
Let me take that down. And it's gone. My fault. All right. So this is the one. All right. Do you want to just, you can.
Oh, did I not get here? Let me, where can I, here, I'll put it, I thought I put it on the contact. I guess I missed it.
I can write it in the chat feature.
Yeah, I'll text it to you right now.
Okay. So I will get that information up. I think the biggest thing to know is Choice, we are a trauma-informed care provider, and with our patients, and we stick to the realm of physical therapy, but we know more now about our patients who have had trauma, who the prevalence of that It could be right next to us on our team or any patient who walks into the door. So we wanted to create this space for that we can share this to our patients through our email, and also be able to just reach out to anybody. Oops, where did that go? Sorry about that. Can you hear me?
Yes.
Okay. I can't hear myself. All right, if you can hear me, I will keep going. I'm not sure. I just got a call that came through, and so my computer got funky. But so we are going to be here if anybody has questions. You can email us through care@choiceptny. If anybody has specific questions for Tracy, you can reach out. You can reach out to us, and I can provide you. Oh, thank you, Lauren. I can add in that email for Tracy at a later date. But thank you so much for being here and explaining this conversation that, as we discussed, is not always had. So I really appreciate it. And I guess if there's any questions from anybody, let us know through our email, and we will hopefully reach out to anybody who does.
Thank you so much, Erin. I sent you the email address, and I put it in the chat, and so hopefully we can get it that way. Sorry that I'd given you the wrong one earlier, and I appreciate everyone who joined us. And thank you for all you do at Choice. I really appreciate it.
All right. Thank you, Tracy. We'll talk to you soon. Bye, everybody. Have a great rest of your Friday and a great weekend.
Have a great weekend, everyone. Thank you.
All right. Bye.